Boa noite a todos. Nós iremos hoje, Professor Eisen, I will say in Portuguese, but then just to make the greetings, and then I will talk in English, okay?
Okay. Okay.
Boa noite a todos. Nós iremos, então, apresentar os updates do guidelines do cuidado de receptores, Task Force 4 da International Society of Heart Lung Transplantation. Hi everyone, we are going this night to present the updates guidelines of International Society of Heart Lung Transplantation, Task Force 4. And we are pleased to have Professor Howard Eisen, who is the president of the next Congress in Denver from International Society of Heart Lung Transplantation. And Professor Paulo Pêgo, who is the council President Council of ABTO, and full professor of thoracic surgery at the University of São Paulo Medical School. Professor Eisen is professor of Pennsylvania State University College of Medicine. Professor Eisen, do you want to talk at the beginning a little about the Congress, in Denver, or
yeah,
at
sure.
the end? Yes, please.
Sure. So I'm the program chair, the chair of the program committee for the 2023 annual meeting and scientific sessions of the International Society of Heart and Lung Transplant. And we are putting together the program now, and I think in the next 4 to 6 weeks we'll be completed. Estela has been working very hard with us. We have had more symposium proposals submitted than ever in the history of the ISHLT. We now have abstracts being submitted. And so the program will be very, very exciting. There'll be very interesting symposia. We're going to do somewhat different formats. Something that I learned from the American Heart Association called gamification, where people discuss the pros and cons of certain therapies, and also a format called pecha kucha, which means chit chat in Japanese, very commonly used at the AHA meetings, where there are several speakers, each speak for about 20 seconds per slide. So they're quick talks, all on a unified theme. And we have a number of very, very prominent speakers for the general, our general session. So we're very enthusiastic, very excited about what's going to happen in Denver. It's going to be in the middle of April, so hopefully we won't have a lot of snow, but it could be iffy, but I'm sure it'll be very pretty. But so please feel free to come up. I encourage all of you to come up. We'll show you a good time and you'll learn something. And Estela, thank you for all your help on the program committee.
It's very welcome. And you know, I would just want to send you a mail that I'm ready to help in everything that you wish that I do that. Okay, not just to the topics, but in everything. I appreciate you participate in the program committee. So now, Professor, you can start your lecture.
Okay, thank you.
Please.
Oh, one other thing is that we're going to have, for the first time, a symposium in Spanish. There's a group called ISHLT in Espanol, and they have put together a symposium. So it may not be that far in the future when we have a symposium in Portuguese too. So we're open to all that. Okay, so here we go. We had, over the past 2 years, a group of committees that reviewed and revised the guidelines for the care of heart transplant patients, which were first published the ISHLT guidelines in 2010, and there were 4 task forces, each tasked with a different part of the management. Estela chaired one of the task forces. I chaired this one, Task Force 4, which really is long-term care and prophylaxis. And so I'll focus on what's new, because there are a number of areas that are new. I have no financial conflicts. And I want to say that I actually have never been to Brazil, but I've been pretty close. I was about almost 3 years ago in Iguazu Falls, and on the Argentine side, so which I hear is not the really nice side, but I could see the Brazilian flag. We didn't have time to go over there, but someday. So our task force covered all of these topics, including the frequency of routine tests and clinic visits, prophylaxis for corticosteroid-induced bone disease, exercise, nutrition, physical rehabilitation after heart transplant, management of intercurrent surgery in heart transplant recipients, which is a new area, reproductive health after heart transplant, psychological and psychosocial area issues related to adherence. And then in addition, substance use, endocarditis, return to work or school, and occupational restrictions, operating a vehicle, family screening. Family screening reflects the awareness now that a lot of heart failure is caused by familial diseases, genetic abnormalities, and also many of the patients that we transplant will have familial or hereditary predilections to developing cancer. So how do we manage them? Management of transition from pediatric to adult care, principles of shared care, traveling after heart transplant, and then emerging pathogens, epidemics, and pandemic considerations, which of course were front and center for what we were thinking about. This is Task Force 4, so we had a group of stars from a variety of countries around the world contributing. So the frequency of routine tests and clinic visits in heart transplant patients were not terribly changed from previously, except for item 6. We do blood work, we review medications, if necessary, do echocardiography, annually coronary angiography, and depending upon the transplant center, may do intravascular ultrasound, do endomyocardial biopsy, and more frequently in the United States, we do non-invasive rejection monitoring with gene expression profiling, or the AlloMap, which looks at changes in gene expression and can identify patients who have immune activation and should get biopsied, and more significantly, patients who don't need to get biopsied, so we can cut down the number of biopsies. And then more commonly now, donor-derived cell-free DNA, which is a marker of damage to the transplant, and so can tell us when to biopsy, and also beyond the first year post-transplant, identify patients who may be at risk of developing cardiac allograft vasculopathy, and then finally interactions with members of the multidisciplinary team. And I'm going to talk about extent of the recommendation and the level of evidence. Class 1 is recommendation is something that you should do. Class 2A is something that you should consider. Class 2B is something that might be a good idea. And Class 3 is something you shouldn't do. Level of evidence A is something that is a situation where there are multiple randomized clinical trials that support the recommendation. Level of evidence B is where there's maybe 1 or 2 clinical trials, and level of evidence C is more conventional wisdom, just what people in general agree upon. In infants after heart transplant, there are far fewer biopsies done due to the need for general anesthesia, the difficulty of venous access, and biotome manipulation. And there's no consensus on the frequency of endomyocardial biopsies. So ancillary non-invasive modalities are used more commonly, such as echocardiography. And the frequency, it is lifelong, and it is recommended to assess the presence of acute and/or chronic rejection look at chronic use and toxicity and drug interactions of immunosuppression, and the risks of developing infection and malignancy, assess and manage comorbidities, diabetes, hypertension, need for counseling, planning, and co-management for life events such as pregnancy, increased management complexity and graft-specific issues such as tricuspid regurgitation, the need to reduce emergency department visits and hospitalizations, which was especially important during the pandemic. And then finally, there must be a multidisciplinary team that manages these patients. So in terms of the frequency of testing, there was no change from 2010. For an uneventful recovery, follow-up visits can be scheduled every 7 to 10 days in the first month after heart transplant, and every 14 days during the second month, monthly during the first year, and then every 3 to 6 months thereafter. And there will be a table, it's not here, in the final manuscript, which will come out in 2023, that will show this. And these are reasons why patients should come into the transplant center or be seen as outpatients. Changes in any medications, hypotension, unexplained drop in blood pressure, increase in resting heart rate, fever greater than 101, greater than 2-pound weight gain in a week, unexplained weight loss, elective surgery, increased shortness of breath, pneumonia, respiratory infection, syncope, chest pain, abdominal pain, nausea and vomiting, cerebrovascular events, and suspicion of pregnancy, as well as exposure to contagious infectious diseases. So heart transplant patients, because of their chronic use of corticosteroids, are at risk of corticosteroid-induced bone disease. So all adult heart transplant patients should be screened for pre-existing bone disease, preferably the time on the waiting list, waiting for transplant, using clinical fracture risk assessment. In adults, we use bone metallic density assessments using X-ray absorptimetry or the DEXA scan of the lumbar spine and femoral neck. And all patients on long-term immunosuppression with glucocorticoids or calcineurin inhibitors should have annual, which while they're on steroids is annual assessment of bone mineral density. And heart transplant candidates and recipients should have recommended daily allowance for calcium, depending on age and menopausal status, vitamin D, necessary to maintain appropriate vitamin D levels above 20 or 50. And heart transplant recipients should have periodic assessments of serum calcium and vitamin D levels. We do it usually every 6 months while they're on steroids, then annually thereafter. Regular weight bearing and resistance training should be encouraged to increase bone density. Lifestyle modifications should include maintaining healthy weight balance, balanced diets, smoking abstinence, and limiting alcohol intake to 1 to 2 drinks at most per day, and probably less than that. And the prophylaxis, I guess I can skip this, but we recommend annual DEXA scans in the first few years while they're on steroids. And we will use biphosphonates in the first year to reduce fracture risk. And if there's evidence of bone loss on DEXA scan, we'll use biphosphonates in addition to calcium and vitamin D. But there has to be care when using biphosphonates. There are risks of jaw fractures, so one has to weigh the pros and cons of using these drugs carefully. Exercise, nutrition, and physical rehabilitation was updated for the new guidelines. So we recommend performance of aerobic training for adult and pediatric patients when physically and medically able. And this improves exercise capacity and may counteract some of the adverse events that can occur post-transplant, like obesity, hypertension, glucose intolerance. And exercise-based cardiac rehabilitation has been shown to reduce readmission rates at 1 year post-transplant. So the specific recommendations, 150 minutes per week of moderate intensity exercise, or 75 minutes per week of vigorous intensity aerobic exercise to be encouraged for long-term cardiovascular health. And this can increase peak heart and aerobic power and should be considered in any post-transplant patient who can tolerate it. And the emphasis now has been on home-based cardiac rehabilitation, which was especially important during the pandemic as an alternative to those patients who cannot go to center-based cardiac rehab programs. And this is a combination. A hybrid cardiac rehabilitation program can also be done with both home-based and center-based rehab. And we very strongly emphasize that, especially in the first few months post-transplant. Mobile health for assessing, promoting, and monitoring physical activity and fitness should be considered in heart transplant recipients. And age and developmentally appropriate exercise intervention in pediatric heart transplant recipients can improve endurance and should be discussed with all pediatric heart transplant recipients and their parents, along with providing exercise programs and diaries utilizing electronic online technology to capture performance and provide motivation. And timely nutritional assessments and interventions in pediatric transplant patients are, of course, important. And the goal is to maintain a healthy weight, BMI, and reduce the risk of diabetes, hypertension, and dyslipidemia. And as part of our transplant team, we have a nutritionist who evaluates patients pre and post-transplant. Weight management strategies should be employed to ensure a healthy weight and avoid both cachexia and obesity. Cachexia and morbid obesity are associated with increased post-transplant mortality, and morbidly obese patients are at risk of higher risk of rejection, and underweight patients are at risk of higher risk of post-transplant infection, and the risk for dialysis is higher in morbidly obese patients. And of course, patients are on corticosteroids, which can result in weight gain. So obesity is associated also with hyperlipidemia and hypertension, and could affect eligibility for retransplantation if that's necessary. So nutrition and exercise programs to encourage maintenance of healthy weight pre and post-transplant may need to be instituted. So this is a topic that has become important, which is management of intercurrent surgery in heart transplant recipients. So how do we administer immunosuppression non-orally in patients who will not be able to take oral medications because of surgery? So one can switch oral administration of cyclosporin to IV administration, and the conversion factor is the IV dose is 25 to 33% of the oral dose given as continuous infusion over 24 hours. Nowadays, we use tacrolimus much more frequently, and this can be given in 10 to 33% of oral doses of continuous infusion over 24 hours, or as an intermediate infusion, but more commonly, we use sublingual administration, which is much easier. And there, the dose is 50 to 60% of the oral dose. And for mycophenolate intravenously, it's the same as the oral dose. Corticosteroids, the same as well. For CMV seronegative transplant recipients, low-risk CMV packed red blood cells should be considered. And ABO-incompatible heart transplant recipients require specialized blood products at the time of surgery. So immunosuppression should not be discontinued or modified without discussion with the heart transplant team. So if there's surgery, it needs to be discussed with the team. It may be prudent to admit the dose of CNI, cyclosporin, and tacrolimus the morning of surgery to avoid potentiating detrimental effects of dehydration on renal function. After that, immunosuppression can be continued as normal. And as mentioned, we like using sublingual tacrolimus as the easiest way to continue tacrolimus. The mTOR inhibitors are proliferation signal inhibitors, such as everolimus and sirolimus are more commonly used nowadays. And these can inhibit wound healing. So we believe that they should be interrupted, ideally up to a month prior to elective surgery, and that patients be switched to mycophenolate with switches in CNI dose, and that the PSI inhibitors PSIs be started once adequate wound healing has been achieved, and that's usually 14 to 21 days post-surgery. In the event of urgent surgery, severe open wound complications or urinary fistulas have been identified, but usually for elective surgery, we try to stop the PSIs 2 weeks to a month beforehand, then start them about 2 weeks afterward once wound healing has been achieved. And there should be steroids should be minimized or reduced prior to surgery. They also affect wound healing. Individualized perioperative corticosteroid stress dose based upon patient's history of corticosteroid intake combined with type of surgery. And consideration should include adverse events, including hyperglycemia, infection, hypertension, and poor wound healing. Reproductive health is something that has also received a renewed interest by the task force. So a multidisciplinary team involving specialists in maternal and fetal medicine, cardiology and transplant medicine, anesthesia, neonatology, mental and behavioral health, and genetics are important in the care of pregnant heart transplant recipients. In the case of infertile female heart transplant recipients, patients who wish to become pregnant and require ovulation induction or IVF should be carefully counseled about the major potential side effects such as hyperstimulation syndrome and multifetal pregnancies. A single embryo pregnancy is ideal in these patients. And the other interesting thing is that with the exception of mycophenolate and the PSIs, the other drugs, steroids, and tacrolimus and azathioprine are considered safe in pregnant women. They are not associated with increased teratogenicity. They're associated with a modest increase in premature births, on average about 2 weeks. There's a very large pregnant transplant registry in the United States that has really evaluated this, but a patient who's considering becoming pregnant, who's taking mycophenolate, should be switched to azathioprine. So it's really the one circumstance where we use azathioprine nowadays. Or if they're taking sirolimus and everolimus, again, they should be switched to azathioprine. The 9-valent human papillomavirus vaccine may prevent persistent HPV infection, cervical and vulvovaginal cancer, precursor lesions, and genital warts. So individuals should receive all 3 doses before heart transplant if possible. If there's a contraindication to administering the vaccine to women after heart transplant, the quadrivalent should be administered. Patients, there's decreased response to vaccines post-transplant, so we try to vaccinate everybody pre-transplant, and we have a requirement that patients are up to date on their vaccines, including the HPV vaccine, hepatitis B, influenza, and the non-viable varicella zoster, and COVID-19. And I'll talk about COVID-19 a little bit later, but we will not list patients who are not vaccinated. Topic 6, psychological issues, particularly related to adherence. So given the high prevalence and negative impact in graft function and survival in pediatric and adult heart transplant patients, adherence, not just for immunosuppression, but for all medications, is critical. Electronic monitoring is a gold standard. It is complicated, but can capture day-to-day variation in medications. It may not be feasible in all patients. One thing that we have a pharmacist who works as part of our team, and she will check on the refills of medications at the patient's pharmacy. So that's one way that we've been able to follow adherence. And factors hindering adherence need to be discussed in an open, non-threatening way during visits with heart transplant recipients. Patient-related factors most commonly are associated with non-adherence, including ongoing assessment and intention, our knowledge and skill levels, intention, motivation, and either personal or environmental constraints preventing patients from acting on their intentions. And as I'd mentioned, attention should be given not only to adherence to immunosuppressive regimen, but to adherence of other medications such as antihypertensives, statins, and prophylaxis against infections. Patients at risk should be monitored for the presence of delirium. And acute delirium treatment should include antipsychotic medications. And pediatric and adolescent patients may be at greater risk of mental health comorbidities related to psychological and physical changes associated with puberty. We usually don't see these patients in the adult world, but I'm sure Estela is very, very familiar with this. And pediatric heart transplant programs should have access to psychiatric services. Screening for depression and mood orders should be routine before and after transplant, with attention to the family unit and referral to a psychologist or social worker for routine follow-up. We have social workers and psychologists as part of our team. Substance abuse, active tobacco use, smoking or chewing is a risk factor for poor outcomes after transplant and is an absolute contraindication for transplantation. And education on the importance of tobacco cessation and reduction of environmental or secondhand exposure should be performed. Patients with a smoking history should be regularly screened for smoking resumption using reliable objective measures. So what we will do is smokers, we will tell them to stop smoking if we're evaluating them for transplant, and we'll monitor them every 6 months with random urine nicotine screens, and only after they're negative for 6 months will we then list them. And people with a history of smoking, we will screen them post-transplant with random urine nicotine screens. And all patients who resume tobacco smoking should be referred to appropriate specialists for evaluation and possible cessation therapies. E-cigarette should be avoided as a tobacco cessation aid, as there's limited data to support either efficacy as a smoking cessation or safety of long-term use, and vaping is associated with cardiovascular and respiratory disease. Alcohol should be avoided, and patients who misuse it should be referred to appropriate support and treatment services. And all patients should be routinely assessed and questioned regarding substance use, opioids, methamphetamine, cocaine, and patients screened who are at risk should be screened for substance abuse. Patients testing positively for these should be referred to appropriate services for treatment and support. And patients who we see who are using these drugs, obviously they have to quit and abstain entirely, and we will screen them with random drug screens as well for 6 months pre-transplant, and they'll have to be negative for 6 months. So what to do about cannabis and cannabinoids? This is becoming more of an issue in many places in the United States, including Pennsylvania, where cannabis is now legal for medical therapy. And actually, the site where we're going to have our next ISHLT, Denver, cannabis is legal for recreational use. We believe that cannabis dependence is associated with elevated risks of non-adherence or other negative behaviors, and that smoking marijuana can put patients at risk of pulmonary infections. So we mandate that patients not smoke marijuana. We do random urine random urine drug screens for cannabis. And if cannabis products are used for medical reasons, they have to be managed by the appropriate medical professionals. Endocarditis prophylaxis. There's insufficient data to support specific recommendations. Patients at risk for acquired valvular dysfunction are advised to get antibiotic prophylaxis for dental procedures, and this recommendation is unchanged from 2010. Returning to work, it should be recognized that the goal for heart transplant recipients is that they return to work as early as possible, and they should be supported and encouraged to do so. Return to work should be the goal of post-transplant rehabilitation, and post-transplant employment is associated with better health-related quality of life, lower physical and psychosocial disability, short-term and long-term, and patients should be encouraged to maintain their jobs as long as possible before heart transplant, as a shorter duration of unemployment prior to transplant facilitates the return to work afterward. Of course, some patients are so sick that they're hospitalized, but those who can be at home should be encouraged to continue to work. A reduction in working hours should be considered if there are physical limitations. And short-term and long-term goals for returning to work should be discussed prior to transplantation, as well as part of the discharge planning after heart transplant. And that, depending upon the job, content, and post-transplant physical recovery of the patient, employment can be resumed within the first 6 months, initially as part-time and then full-time. Return to work becomes less likely if patients delay 6 months or more. Return to school. Pediatric and adolescent transplant patients and their families should be able to return to school after initial recovery, and developmental outcomes span the range from normal to subnormal, and these individuals may require targeted support and may also have specialized needs around minimizing infectious exposures that put them at serious risk, more so than the non-immunocompromised peers, and consideration of placement in the classroom or accommodations to continue to learn while avoiding potential dangerous infections. School-age transplant recipients should be formally screened for neurodevelopmental deficits after heart transplant, and educational assistance should be provided in case of learning disabilities, and referral to developmental specialists should be considered. Operating a vehicle. So population of heart transplant recipients is heterogeneous, so there should be an individual assessment for the ability to drive motor vehicles. Reasons why they shouldn't drive motor vehicles include neurologic abnormalities, poorly controlled diabetes or hypertension, cardiac allograft vasculopathy, the transplant coronary disease, recently treated rejection episodes, heart failure, and arrhythmias. And there are really two groups of drivers. Group 1 are drivers of private vehicles, small and low-weight vehicles. Group 2 are professional drivers, large and high-weight vehicles, generally professional commercial use. Timing of driving after heart transplant. Patients should wait until there is wound healing, clinical recovery, and return to normal physical and cognitive functioning. And Group 1 driving may be allowed if the recipient is clinically stable, with reference to these. Group 2 may be allowed after intentional individual assessment by a specialist, and arrhythmias should be considered separately. History of syncope or the presence of limiting symptoms should be considered before driving is permitted. And absence of malignant hypertension should be ascertained before heart transplant patients are permitted to drive. And the assessment of the New York Heart Association functional class. If patients are severely limited, they should not be allowed to drive commercially. In cardiac allograft vasculopathy, because of the risk of sudden cardiac death, is considered a risk factor for driving. Following a hemodynamically significant allograft rejection episode, the heart transplant recipient should refrain from driving for 2 weeks after the episode. Family screening. So physical examination of the explanted native heart is recommended for all transplants. and physical examination of explanted allograft hearts recommended for all retransplants. And this should include gross histological and appropriate genetic testing. Outcomes of explanted heart examination should be conveyed to the primary heart transplant team so they can inform the patient about the risk of any family members developing heart disease. And providers should have a thorough knowledge of an individual transplant recipient's previous anatomy and physiology, including review of all surgical and procedural records. In case of congenital heart disease, a fetal echo is warranted in the offspring, and the parents should be counseled by a pediatric cardiologist specialized in fetal cardiology in close cooperation with fetal medicine specialists, and there should be a multidisciplinary team. Skip that. Genetic testing is recommended in all patients with suspected genetic abnormalities and a history of parental consanguinity, preferably during evaluation for heart transplant. And so one thing that we've found increasingly is patients who have idiopathic dilated cardiomyopathy often have family members who have had dilated cardiomyopathy and also have genetic causes. And so we recommend trying to identify the causative mutation in the proband and then do genetic testing of first-degree family members. And then finally, genetic testing is important in patients with malignancies. So, and there are specific malignancies where this is important. So patients with a history of breast or ovarian cancer should be checked for the BRCA genes, BRCA1 and BRCA2. And consideration should be given as to whether prophylactic surgeries like mastectomies and oophorectomies should be performed in patients with strong family histories of breast and ovarian cancer who are BRCA1 or BRCA2 positive. And those patients need to be very carefully screened post-transplant. And there are other genes which predispose to malignancies. So, for example, CDH1 predisposes to the development of gastric carcinoma. And these patients, regardless of whether they undergo a transplant or not, should undergo prophylactic gastrectomy. The strategy should be considered in patients who have this genetic abnormality and are being evaluated for heart transplantations. Patients with known gene mutations, family histories of malignancies, and prior malignancies should be referred to cancer risk assessment programs at cancer centers and post-transplant screening of patients who are determined to be at genetic risk and may be different and more stringent than what's recommended by the American Cancer Society and the U.S. Preventive Services Task Force. And what we usually do post-transplant are the conventional things, colonoscopies, mammography, prostate-specific antigen, gynecologic exams, and in patients who have history of smoking, chest CT scans. So whether we should be doing something more stringent is not entirely clear. So management of the transition from pediatric to adult care after heart transplantation. Pediatric transplant care providers should prepare the patient for transition from pediatric care to adult care by encouraging a move toward independence demonstrated by taking on self-care responsibilities and involvement in decision-making, and structured transition programs for adolescent heart transplant recipients should be adopted by pediatric heart transplant centers to increase knowledge and decrease non-adherence. And this should begin from age 12, and tailored solutions to help adolescents take their medications independently should be explored. And the American College of Cardiology has produced a transition of care toolkit, which can be adapted to the practice patterns of international transplant centers. This includes a transition readiness self-assessment, which allows healthcare providers to assess an adolescent's likelihood for successful transition, knowledge assessments, clinical summaries, and emergency care planning that young people can keep and share with adult providers. And healthcare providers should consider developing clinic times or waiting room options more inviting for pediatric patients transitioning to adult care. Principles of shared care after heart transplantation. We have referring physicians. We shouldn't include these physicians. So we provide them with telephone numbers and electronic mail addresses. And primary care physicians are encouraged to follow patients along with the heart transplant team and refer patients whenever there's evidence of the instability or an issue. But we don't really devolve the care too much to the local physicians, except that they're non-transplant related. We do have periodic conference calls with local centers to discuss the care of patients and to enable ongoing discussions and review appropriate management of complications should they arise. Traveling after heart transplant, potential travel should be discussed with heart transplant recipients, and referral to travel medicine with expertise in immunocompromised hosts is recommended, so patients can receive information about safer travel, including, but not limited to, food and water safety, zoonotic infections, arthropod-borne infections, and sexually transmitted diseases and malaria prophylaxis. Travel to high-risk destinations is not recommended the first year post-transplant when patients are maximally immunocompromised. But every now and then you get surprised. Last Friday, I saw one of my longtime transplant patients who's stable 12 years out from transplant. And he told me, oh yeah, about a month ago, I was in Egypt. And he read online about what he should do to make sure he drinks safe water and eats safe food. And he did fine, but it's always a good idea for patients to discuss this beforehand. And last week I had a discussion with a patient of mine who's 25 years out from transplant, and she is a real world traveler. She's been to India, Ethiopia, Brazil, Suriname, all over the place. And she's going to Namibia. So we looked up what she should be careful about. Routine non-live vaccinations should be up to date, including those that are unrelated to travel and those that are related to travel. And travel-specific vaccinations will depend upon the destination. Live vaccines should not be given to heart transplant patients, like the live attenuated influenza vaccine, oral typhoid, oral polio, or the live zoster vaccine, as well as the other live vaccines, even live attenuated vaccines. So the big change has been the guidelines in terms of how to deal with the pandemic. So many programs had temporary suspensions in their transplant activity during the pandemic for several reasons. One was that we didn't want patients coming in and being exposed to the virus in the hospital, and then when they're maximally immunosuppressed, being exposed afterward. We didn't want our transplant teams being exposed when they went to harvest hearts at other centers. And so for a while, early in the pandemic, our transplant team was not allowed to go to New York, which had very high rates of infections. But we never suspended our program and continued to do transplants. We did inform our transplant candidates. It should be informed of the center's policy to assess the risk of novel pathogens and pandemic illness transmission. And so one area of discussion in the United States is whether we should be taking donors from COVID positive, organs from COVID positive donors. And I think the jury's still out on that one. There's still discussions and there are protocols being developed. There has to be a multidisciplinary approach to how to handle patients during pandemics, how to minimize the risk of disease transmission to the transplant team, to the transplant recipients, and management of heart transplant patients with active infections, including the use of investigational therapeutics, and also alterations in immunosuppressive therapy and timing of biopsies. So in some of our patients, we actually decreased their mycophenolate because there was evidence that patients in mycophenolate had worse outcomes if they got infected with COVID. One other thing that we did was we made efforts to reduce visits by clinically stable heart transplant patients to medical facilities, including the hospital and outpatient labs. And we did this by doing blood testing at home. So we'd send teams to the patients' homes to get blood tests. And one thing that we did was to use gene expression profiling and donor-derived cell-free DNA assays to determine whether patients needed to get biopsied. So this way, patients wouldn't have to come to the hospital to get biopsies or get labs or go to local outpatient labs. And we could determine whether they're at risk of rejection or not. So we're able to minimize biopsies and minimize exposure to infected to infection by having them come to healthcare facilities. As I mentioned earlier, we do require our patients to be vaccinated against the broad group of infections: Hep B, varicella, influenza, also COVID. And we will not list patients unless they're vaccinated against COVID. And this has been a controversial issue in some centers in the U.S., and some centers have been accused of letting patients die because they have advanced heart failure and not get transplanted. Our approach, if patients absolutely refuse to get vaccinated, is to put ventricular assist devices in as at least destination therapy. If they decide to get vaccinated, they can be switched to bridge to transplant. So that's one way of keeping people alive, treating their advanced heart failure without if they refuse to get vaccinated. And this is so the ISHLT recommends vaccinations, all pre-transplant vaccination of all solid organ transplant candidates is a priority. Vaccinations in solid organ transplant recipients and priority for vaccination of their household members and caregivers to reduce exposure to these vulnerable patients. Continuation of stable immunosuppression. Live viral vaccines, even if attenuated, should be avoided, but we recommend using mRNA technology, which is safe in immunocompromised patients. The efficacy may be reduced, so we recommended patients get the third and fourth shots, the 2 boosters, and we're going to recommend that they get the new booster that's coming out in September that's directed against the newer Omicron variants. Data indicates reduced vaccine efficacy in immunocompromised patients. Serum antibody assessments can be done routinely, although much of the response to COVID is T-cell based, so antibodies alone may not tell you how immunized the patient is. And there's reduced efficacy of the new vaccines in immunocompromised patients. A 3rd dose is recommended and perhaps a 4th dose. And we've also recommended in patients who are within 1 year post-transplant and are vaccinated that they get the ISHLT, which is a prophylactic drug given in patients who do not have COVID but are at risk of getting exposed to COVID. So you may be saying to yourself, wow, these people have been really productive during pandemics. And it turns out that productivity is a hallmark of pandemics and of plagues. So let me give you a few examples from history. In the early 17th century, 1605 to 1606, William Shakespeare went into isolation during the bubonic plague outbreak in London after the theaters, including his, the Globe, was shut down. During self-isolation, he was inspired to write 3 of his great tragedies, including King Lear, which directly references the plague, Macbeth, and Antony and Cleopatra. 1665 to 1666, Isaac Newton retreated to his family farm from Cambridge after the outbreak of the Great Plague in London and Cambridge, the worst plague in Britain since the Black Death. While in self-imposed isolation, he helped to develop calculus. In 1722, Daniel Defoe, after his big hit, Robinson Crusoe, published Journal of the Plague Year, an account of the Great Plague of 1665, to warn his largely indifferent countrymen about the plague emerging on the European continent that would befall them. And my daughter, who's a historian, asked me what I was doing during my isolation during pandemic. One of the things I was doing was working on the guidelines. One more example of productivity during the pandemic, Edvard Munch, the Norwegian painter who survived the 1918 Spanish flu, painted a self-portrait of himself while he had the flu. And then after he recovered in 1990, he painted this picture, which is pretty much how I looked early in the pandemic, except for the tie, but he made it. So I'd like to thank you for inviting me to speak. Thank you. Muito obrigado. Thank you very much. And I guess good evening is boa noite. I'll get my Portuguese better. But thank you very much for your kind invitation. I hope to visit you guys and actually be in Brazil and not see it from the less attractive Argentine side. But thank you again.
We really appreciate Professor Eisen for your excellent lecture. I'm not sure if is there any questions in the chat. I have one question, some questions to you, but
Sure.
we have a limit time, just almost 7 minutes.
Okay,
But
I'll speak quickly.
yes, I would like to know nowadays what's your indication for retransplantation for CAV. How in your center, how you indicate the retransplantation when there is a dysfunction in long-term follow-up?
So we're actually grappling with that right now. We have a patient, a longtime patient of mine who's 22 years out from transplant and who developed chest pain and has severe 3-vessel coronary disease. So we will retransplant patients who have evidence of heart failure, who have severe 3-vessel disease, the ISHLT grade 3, and who are symptomatic, have heart failure symptoms. We will retransplant them. And of course, we don't retransplant anybody who has allograft dysfunction from rejection, because those people will just reject post-transplant. But we do retransplant people with severe CAV, evidence of allograft dysfunction, hemodynamic compromise, and multi-vessel disease.
I'd like to thank you very much for your talk. It's excellent as usual. And I'd like to remember you that I invited you to come here to Iguaçu Falls some years ago.
Yes.
In a joint symposium with Brazilian Association and ISHLT. And but at that time you can't come. So I will invite you again.
Okay, absolutely.
To come here. It will be a pleasure and an honor to receive you here in.
Love to go. Yeah, I couldn't make it that time because I was on the board and they had a board meeting and they said, well, you have to go. So actually, and the board meeting was outside of London. So I tried to figure out, could I go to your meeting and then that meeting, and it wasn't possible. They were almost simultaneous, but I'd love to visit.
Yes, I know. But it will be a pleasure to receive you, in Brazil, certainly. I'd like to ask you another question that is about our registry in international society. You have some problems in the past with the law, because instead we are sending our data from Heart Institute to there, to lung transplantation, pediatric heart transplantation too. And after we receive our order to not to send more because we have problems with law, and nowadays you can send again, but only Brazilian data, I think, only the data, the whole data of the country, or not, or no. I don't know at this moment what is your recommendation about to receive our data. Do you know?
Well, there's now going to be a transition in the leadership of the registry. So Joseph Stellick, who's done it for 10 years, is retiring from that role, but Rebecca Cogswell from the University of Minnesota is starting up. So I will email her to contact you about this. And she's very good. She's, very proactive, hard worker. So I'll ask her to reach out to your center and to the Brazilian centers and see what can be done to make sure that the data comes in and that you're represented in the registry. I know that for Joseph, it was a high priority getting everybody worldwide to be represented in the registry, and I'm sure for Rebecca it will be as well. I'll ask her to contact you.
Thank you. Thank you so much. Thank you again. Stella, do you want to ask another question or not? I think that the time is more or less over.
Yes, just one more question regarding positive donors with COVID. Are you using that or not in your center?
We're discussing it, and we're looking at some of the experience that other centers have had. Cedars-Sinai in California and Allegheny General in Pittsburgh. The Allegheny General group, Manrit Kanwar, has published it in ISHLT. So our thoughts are that we would use donors who did not die of COVID. So they just are incidentally infected, and who have no evidence of thrombus, obviously in the heart or elsewhere. But we're discussing it now and reviewing the data that are there from other centers, and we anticipate doing it in the next few months. And there's also a group called the Disease Transmission Advisory Council, which is part of the Health and Human Resources Administration, which provided recommendations and had a publication, but they presented their recommendations at the American Transplant Congress last June, also in Boston. And so their view is, at least for liver and kidneys and hearts, that COVID positive donors, as long as they didn't die of COVID, can be used. And Cedars-Sinai has actually taken lungs from COVID positive donors, which I think is pretty courageous, and they've had decent outcomes. So there's actually more experience in liver and kidney transplants, but our thought is that we will be, within the next few months, taking COVID-19 positive donors. When we do, I'll tell you what our protocol is. I'll share our protocol with you.
Okay, great.
And we do take, I'm not sure if you're doing this, we do take hepatitis C positive donors. We started doing that because it increased donor availability. And also, hepatitis C is one of the few viral diseases that can be completely cured and eradicated. And the drugs don't have significant interactions with immunosuppressive drugs. And also, the insurance companies agree to pay for the drugs. So we've done that, and there's almost uniform infection of recipients who get hepatitis C positive donors, NAT positive, so it means they're truly infected and have the genome. And there's almost uniform eradication of the infection with a 6 to 8 week course of antiviral drugs.
Great. Professor Paulo, do you have any other questions to ask to Professor Eisen?
No, I'd like only to thank again. It's a pleasure to see you, even
Good to see you too.
Only the video. It's a great pleasure. Thank you very much for all your support during these years.
It's a pleasure.
In the society. So thank you very much. Thank you again.
Thank you. Thank you.
Yeah, thank you. So
Boa noite.
Okay. Boa
Good
noite.
evening. Thank you very much.
Okay. Thank you.
Bye-bye.
Thank you.